Thank you to the MGFA for inviting me to be here. My name is Dan Larriviere. I'm a neuromuscular physician at the Ochsner Neuroscience Institute down in New Orleans, where it's much warmer than it is here. Today we're going to be talking about how to get the most out of your clinic visit. And before I do that, how many of you folks with MG were diagnosed in the last 6 months? We got some rookies. How about over the last year? And how about more than 2 years? A couple. Okay, some rookies and some veterans then. All right. These are my disclosures. None of these have any bearing on what I'm going to talk about today. I know Alnylam is working on an MG drug, but I'm not a part of that group. And I'll be discussing some off-label use of medication, since in MG almost everything is off-label. Okay, so here's what we're going to talk about today. I'm going to start with some background conditions and a proposed framework for thinking about going to your clinic visit with your physician. Most of these things are common sense and things that you guys have probably already thought about, but I just want to set some background conditions before we get into the outline itself. We'll talk about some things to do for pre-visit preparation before you go to your doctor, what to do on visit day, what to do between visits, and then hopefully I'll get done quick enough where we can have some time afterwards to talk about some of the things that you guys do and have found to be helpful, and we can sort of let the collective wisdom of the group inform us a little bit better. So we'll start with background conditions and a proposed framework. As we all know, physicians are human, and they're really busy. We see a lot of patients every day, probably too many. It's a result of lots and lots of factors that cause us to have to see more patients than we should each day. But we also know that patients are human, and I'm saying this is human, it's self-evident that that's the case, but I think sometimes that fades to the background, and you'll see, I'll bring that up a little bit later. But we know that patients don't spend a lot of time with their doctor, and they probably don't get to spend as much time with their doctor as they'd like to or as they need to. So both of these things are operative anytime we meet with patients in the clinic. And everybody, the physician and the patient, want to get as much out of that clinic visit as we can, and there's a lot of pressure to try to get everything done in that little bit of time that you have together. And I think it's okay to acknowledge that, and everybody's aware of that, and it's better to put it out front than leave it in the background. So here's the shot. We spend about 1.25 hours with our doctor every year over the course of the year. If you're an MG patient with a 30-minute visit, see them about 4 times a year. Maybe there's some little variances there, but about 1.5 hours over the course of a year. There's 8,759 hours in a year. So most of the time, you're doing your MG yourself. You are there with your disease every day. You get to see the physician 1 hour, 1.5 hours a year. So it's you guys that are managing this. And that's important. I think the proposed framework that I've been thinking about is stuff that you guys probably already know. You need to form a partnership with your doctor, your caregiver, your friends, the MG community, to take charge of your health and be a steward of your own health. And that is what this meeting is about in large part, is how can you do that? Over the last few days, I've heard some great questions from folks with MG, just fantastic insight and thinking about ways that you can empower yourself to deal with this disease. And that's really what I'm suggesting today too. And the goal of any partnership is to get from point A to point B. And in this case, my cousin he's a Marine aviator, and he's a flight instructor for the Marines. And so he sits in the back seat of a really expensive plane and tries to teach people how to land it. And what they're doing is very complex. They're trying to get from the air down to that little bitty boat on the water, and they're moving at incredible velocities with highly flammable jet fuel and highly explosive ordnance, and they try to do it without ending up like that picture on the bottom right, and they try to look like the picture on the bottom left. They have a specific goal, and my cousin's job is to keep the trainee inside the box, and the box is what they call their skill set. And I like this framework for thinking about patient and physician relationships, because I think the longer that I work with an MG patient, the longer an MG patient has the disease, the larger their skill set grows in order for them to manage the disease on their own. Not quite on their own, but for that 8,700 hours, they can do this. So my job is to keep them inside the box and grow the skill set so that they end up having the outcome that we all want. So this is just my sort of shorthand sketch of what the goal or the course of an MG patient's disease experience is like. And this is all subject to lots and lots of variation, but basically there is symptom onset at some point in time, and this is time 0, and this is some time later. They see a doctor for their symptoms, and a bunch of tests are run, and this loop can be big or small depending on how much the doctor knows about MG or has an awareness of MG or has a suspicion of MG. And then at some point they may be referred to another doctor who either makes a diagnosis or who can treat their MG. And then it's a series of therapies that we can try. Maybe they get a thymectomy, maybe they don't, but this is sort of the big picture for MG. Lots and lots of things go on in each of these steps. This is not to oversimplify anything, it's just to give us a framework. And then if looking at it just a little bit differently, this is therapies over time, and so time starting on this side of the slide and going this way. Early on, we may start methadone, a little bit later maybe prednisone with a tapering dose over time. Then we may start immune modulatory therapies. They may need rescue therapies here and there, and then other diseases or disorders or issues come up along the way. So that's kind of where I think patients go. This is kind of where I play with patients with myasthenia. And it's good for the patients to understand this. I try to talk to my patients about this, because this is the big picture, this is what we want to do. And they have an idea of why I'm doing what I'm doing, and we can talk about this every time they come to clinic. So it's easy to say what the roadmap should look like. It's easy to sort of see what the framework is, but we each bring to the encounter a different wheelhouse, a different skill set, right? So physicians are sort of the idea of, doing, and patients are sort of in this zone of being. So as a physician, I want to diagnose you based on your story. I want to try doing a physical exam to make sure that the story and the physical exam match up. I may want to treat you based on my hypothesis on the physical exam and then some laboratory testing, and that may involve some treatment. And then you're going to come back and I'm going to see how that worked, and then we'll do that all again. So it's just this iterative process of listening to the story, making a hypothesis, diagnosing, treating, seeing how that worked. For the patients, though, it's a lot different, right? It's an experiential problem. What can I do? How do I feel? What's going on with my body? Why can't I lift my head above my arm? How come I'm having trouble breathing? What about? Right? And I tell a story. I was working with a patient, this was many, many years ago before I came to New Orleans. She was a woman who was diagnosed with myasthenia in her late 50s or so. Very proper, would always come to the clinic very well-dressed and very reserved, not a lot of emotion, very stoic, and very formal. This was in Virginia, and it was just a very formal woman. And it had been a rough 7 or 8 months after the diagnosis of her disease. She went through a lot, and as lots of people with MG do when they're first diagnosed, sort of contracted everything that she was doing to focus on getting her disease under control. And we were at a clinic visit where she's sort of been stable for a little while and sort of kind of expanding again into her life. And she brought, as she always did, a little checklist of things she wanted to talk about. And she said, can I start driving now? And I said, sure. Checked off the box. Is it okay if I start exercising? I like to walk in the evenings. Absolutely, I think you're ready to do that. Can I go back to church? And I knew that she was very involved in her church. She was on a lot of committees, did lots and lots of stuff for their church. Spent many nights a week there. And I said, yeah, I think you're ready to do that. And then she paused for a second, and she said, what about relations? And in my mind, what I heard was, what about relationships? And my brain connected relationships with church, thinking she wanted to get back and get with her friends. So it didn't really surprise me when I said, you bet, get with everybody at your church, the more the merrier. I think it'll be great for you. And when you do that and your brain sort of freezes time for a second, and then as my statement went out there, I realized it wasn't relationships. It was relations. And I watched the redness of her skin start here and go straight to the top of her head. And I realized what I had done, and I sort of did the best I could, and we regrouped, and everything was okay. But I realized at that point that I have to get better at the being part, right? This is important, and we ignore this at our own peril if you're a physician. And so that's a little bit of I'm going to segue here for just a second. This is something I'm playing around with at Ochsner with a couple of other people. There's a priest named Father Deacon Silas and an ophthalmologist named Dr. Neusdorf, who the three of us are working on a little model for what this continuum looks like, this doing and being continuum. And, we've heard, I like this model for a couple of reasons. One is it's a wheel on both sides. So this is the physician, this is the patient. The wheel implies that this is a never-ending process. It's iterative, right? So if you are a physician like myself, I have to continually try and get better at all of these things. There's diagnosis, there's treatments, there's empathy, there's forming connections. All of these things I have to work on all the time. And as a patient, the patient's role, and you guys work on, is figuring out how this disease integrates into your life. We heard a great story from Mr. Kaufman yesterday about that pathway. It was a fantastic narrative. He used his writing to transform his illness into something that made sense in his life. He integrated that into his life, and that allowed him to heal. And there's lots of different definitions for healing: physical, emotional, spiritual. We could spend a whole afternoon on that. But this is a little model that I like to think about when I'm in the clinic, because I think it's important. And I think what we've heard a lot this weekend about how people do this transformative piece is really, really key. And this is just another little way to look at it. Has anybody heard of Martin Buber? Anybody? Okay. I don't blame you for not having heard of Martin Buber. I didn't either until I spent 4 years at a little college in Texas, in Georgetown, Texas, called Southwestern University. And my intro to religion professor was a German philosopher, and he loved Martin Buber. So I spent an inordinate amount of time reading about him. But it turns out he had a really neat idea about how relationships go. And he said a lot of our lives are spent in what he called I-it relationships, transactional relationships. So if I go to the drive-thru and I order something, that's an I-it kind of thing. The person on the other end of that little speaker doesn't know me, I don't know that person. It's a pure contractual thing. I want this, I'm going to give you money, you give me the food, and then we're gone. It is in contradistinction to an I-thou relationship. When we have relationships with people we know for long periods of time, your spouse, your significant other, your children, you address them in a completely different way. And the work is relational. It's ongoing, and it's deep, and it's committed. We spend, as physicians and patients, lots and lots of time along this continuum. Depending on what disease we have, what kind of mood we're in, and what we're talking about, it can go anywhere along here. And it's important to be aware of that, I think. And this has implications for patients versus consumers, too. And we'll get to that towards the end. So these are the kinds of things I think about when patients come to see me in the clinic, and how is it that we're gonna help them get from point A to point B in this partnership. A lot of what you do with your physician will be in the contractual end, increase my prednisone, I need a new script, I need an appointment, blah, blah, blah. But some of it starts to lean up into this area. My family life is affected, my personal life is affected, I can't go to my church anymore. These are the kinds of things that are important and have to do with healing as well, and they should be raised in the clinic if this is something that you're struggling with. So my point is that we have sort of a different wheelhouse, and both sides have to get a little bit more comfortable with physicians being a little bit more interested in the being aspect of having a disease. And for patients, and I've heard a lot of it here, how are we going to manage my disease? What are my meds doing? Why am I on this dose? When I go to the ER, no, I don't want a peak expiratory force. I want a negative inspiratory force, please. And here's my little chart of all the ones that have happened before, all the ones I've done before. So we're learning a little bit about how to do this better, I think. So let me get back to the main thing. So here's our framework to think about. And then, so what do we do for the pre-visit checklist, if you will? So the first thing everybody has to do is figure out where they're going to go. A lot of this is dictated by insurance. Some of us don't have a lot of choice, but some of us do. But all of these things are things that we should think about. So do I want to see a general neurologist or a subspecialist? Lots of neurologists who are not subspecialists know a lot about myasthenia. Others don't, and it matters. I think understanding after your first appointment how comfortable that neurologist is with MG is pretty easy to do. If you know more about that disease than the neurologist does, maybe you should rethink that relationship, or maybe you want to be a teacher. Just kind of depends on how you're doing. Do you prefer a man or a woman physician? This matters to some people. And if your insurance sort of dictates who you get, how do I deal with that? If it's a person of the opposite gender that I don't really prefer, how can I make that work if I have to make it work? Do I want to go to a teaching institution or to a private practice or a subspecialty clinic where there's not residents and medical students? Knowing maybe I don't want to spend an hour and a half in the clinic going through a resident H&P and then going to talk to the attending, or maybe I do. Maybe I like to teach people about MG, and that's my thing. Small office or a large system, they both have their advantages and disadvantages. And do I want to travel to the downtown area, or do I want to be seen in a suburb? These are all things that sort of are on the table when you start thinking about forming relationships. Are there other docs who can help me with other diseases or issues that I have that may or may not be related to MG? So is there an endocrinologist there? Is there a cardiothoracic surgeon? Are there doctors who understand my diabetes? Are there people here who can help me with other things? And that gets to sort of this integrated idea, right? So do they have an electronic medical record? Can they get records from my outside physicians to come in there? Or do I want to think about getting everything done in one spot, so all my records in one spot? If they have an electronic medical record, which one is it, and does it have a patient interface? Can I email my doc or his nurse or the support group through that interface and let them know what's going on? I have one of my patients emails me a week ahead of her visit and says, this is what I'd like to talk about when we meet next week, in addition to whatever you want to talk about, but here are the things that are on my mind. And I love it. It's very short. There's only like 3 bullets. And she says, these are the things I need to discuss with you. And I like it because then I have, okay, now I know where she is, and now I can put what I need to do and fold it in there. But it's because we have a little patient portal, a little patient entryway, that we can do that. Okay, so to me, this is one of the most important things about being a patient with MG, and you guys can tell me if I'm way out to lunch here, but this is the doing part. This is one of the doing parts of being a patient, and this is what I call your elevator pitch. MG is a complex disease that's supposed to be represented by all this stuff over here. Very complicated, lots and lots of things happen with your illness. Every day is a new day. You begin to see trends over time, and it's hard to convey that nuance in a way that people truly understand, unless you practice. And when you practice, these are the kinds of things that as a physician I'm listening for. These are the things I want to know, especially if it's a first visit. Absolutely, if it's a first visit, I want to know when your symptoms started, because in the first couple years, that's when you're most at risk for having a crisis. That's when you're most at risk for something going from just being purely ocular to being generalized. So I got to understand your risk. So if you tell me my symptoms were started 10 years ago, we're in a different place than if your symptoms started a week ago. I want to know how they evolved. Well, they started in my eyes, but then a couple months later, I couldn't lift my arms over my head. So that tells me, okay, now we're dealing with generalized disease, and we have a vector. It's moving, so I have to be thoughtful about that. And then when was I diagnosed and what my antibodies were. How many of you guys know which antibodies you have and what your titers are, or what the names of your antibodies are? Names of antibodies? It's hard, right? There's a bunch of them. And it's not just AChR antibodies, right? There's subsets of those. There's blocking, binding, and modulating, and striated muscle antibodies, right? Okay. And when patients come to me, I'll ask them the question, do you know which subtypes you are? Because it matters a little bit. It's good to know that and good to have that written down somewhere so you can show your doc, yeah, I got it done, here's what they were. The titers themselves, some docs think titers for individual patients matter and some don't, right? So you'll say, well, titers don't really correlate with disease, and generally that's true, but for individual patients it might. So sometimes docs want to follow that, sometimes they don't. Most of us don't, but sometimes they do. So anyway, so having those 3 things at the tip of your tongue are good. And then if you've been on medications, what are the dates of those medications? How much did you take and what were the results? How long were you on it? Those are all great things to know, because I don't want to put you on something, or I don't want to spend a lot of time talking about a medication you've already been on and failed. So if you tell me up front, look, I tried CellCept for 3 years and it was 1,000 milligrams twice a day and it didn't do anything for me, then I can throw CellCept out the window. We're not going to talk about it. We're going to move on. And that's wonderful for me to hear. What's your functional status generally, right? Good days look like this. Bad days look like this. Days when I'm going into a crisis look like this. perfect. I know exactly what we're going to follow when we talk about treatment. And when you call me on the phone, if you say I have X, Y, and Z, which is those are my barometers for going in the bad direction, then I know that we got to get on the horn and get things going. Have you had any hospitalizations or intubations, and what were the triggers for those? That's all very important for me to know. If you go sideways when you get an antibiotic, we're never going to give you that antibiotic again, and I'm going to make sure I put in the chart that never give this patient this antibiotic, please. And then if you've had other evaluations like CT scans, thymectomies, if you had a thymoma, did you have radiation therapy after the thymoma? Everything right all there at the top. And you can say this, with practice you can get through it in 5 minutes. This. And you can tell everybody that you meet, and you can have your significant other tell everybody that you meet, this is my little elevator pitch, this is my story. So that if you go to the ER and you can't talk very well, your spouse or your significant other can do this too. Here's the deal. And that tells the ER doc, should tell the ER doc, that you guys aren't messing around, you know what you're doing. And gee, when they suggest I call their neurologist, I probably should, because they're way out in front of this, they're more out in front of this than I am as an ER doc. And I love ER docs, by the way. I loved all the axioms that Dr. Allen came up with. DNR does not mean do not try, and if you've seen one MG patient, you've seen one MG patient. ER guys have the best aphorisms. Okay. A couple other pre-visit ideas. If you have a lot of records from doctors you've already seen and you think they're important, it's a great idea to bring them with you if you can. It's not critical, but having your old office fax your new office records is hit and miss, as you probably have experienced. It's a weakness in the system as far as I'm concerned, but a lot of EMRs now are hooking up different institutions. So Epic, which is one we use, and I have no vested interest in Epic. Epic can talk to a lot of other Epic institutions around the country, and so I can pull records in now from other places. So that is kind of going away a little bit. And then this is another one. Know why you're there, or set your agenda. Have an idea in your mind, why am I going to see this person? If it's a new visit, what do I want to get out of that visit? If it's a return visit, what we're doing is we're testing what I just did to you for the next 3 months, right? I want you to go down on your prednisone to this, and 3 months from now, come back and tell me what happened. So when you go back, you're going to say, hey, we moved my prednisone down, and this is what I experienced. And then contribute to the collaboration. What do you want? What do you want when you go there? What are the things that I need to hear about from my doctor today, and write those down, and have that ready to go. Okay, and then on visit day, a lot of this is self-evident. Wear comfortable and appropriate clothing. I have had patients wear inappropriate clothing. I won't go into what that is, but it matters. It matters. If you live far away, consider using a traffic app like Waze. I don't use it too much because I live in New Orleans and we're all about this far apart from each other. But if you live in a big place and you got to commute a long distance, Waze is really nice because it'll tell you if you got to bake in more time to your commute. Google, I think, will let you, if you tell Google where you want to go and what you want to do, it'll also do the same thing. And don't forget parking time. I hate having to park in a big med center with the garage and all that. It takes forever. I understand the pain. But keep that in mind too. That's a time sink. And then bring some supplies because you never know how long a day it's going to be. Bring your medications, bring a book, bring your sunglasses if the bright lights hurt you. And any equipment that you're going to need to get from point A to point B. Sometimes the clinic is a long way from the parking deck, and if you get tired, it's nice to have a place to sit down that you bring with you. And then, once you get in the clinic, the clock starts ticking and everybody's in a big hurry. But, don't dawdle, but don't rush either. You're there to deliver some information, and you're there to get what you need. So being organized ahead of time and kind of having an idea how you're going to do it is great. But, talk to your doc and let them know what's on your mind. And this one here, make sure that what you're taking is what we have in the record. It sounds weird, like, well, wouldn't you know that? And we should. But lots of patients are on multiple medications, and not all of them we prescribe. And you don't always take all of them, and they may not have been taken off your med list since the last time you were at the clinic. Or we could have changed them by a phone call in between clinic visits, and we just didn't capture that in the medical record. It takes 5 minutes usually to make sure that everything looks the same. You probably do that with a medical assistant or the person who rooms you. But, it's a quick, what I see and what I hear is, any medication changes? No, not really. And that's it. And when you have to go to an ER, or God forbid you go to the ER, you get admitted, and your med list doesn't match up with what you're taking, things can happen. So it's an important little nugget that I think we need to spend more time on. And then just walk through everything that you want to talk about with the physician. Let him or her know what's the most important thing, what's the next important thing, what's the next important thing. If you need to, take notes. This is more doing stuff. Take notes if you have to. Ask questions, especially if you're not clear on something. It never hurts to ask. And consider bringing another set of ears. Lots of my patients bring their significant other or a friend just to hear everything so they can debrief on the way home. They can make sure they each heard everything the right way. And make sure you understand the big picture. Go back to that little slide that I said, this is my methadone, this is my prednisone, this is my immune modulatory therapy, and here we are in each of those areas. This is what we're doing in each one. And then what about your non-MG health-related needs? Lots of different things come up for MG patients. High blood pressure because we put you on a lot of steroid, and diabetes for the same reason. Your bone health for the same reason. Eye exams for the same reason. Are you getting those checked? Who's checking them? Where are they checking them? What does my neurologist or my physician need to know about all that? If it is a first-time visit and you're looking for a primary care doc, you can ask your doc, do you have primary care docs who know what MG is and are familiar with it and know not to give me a Z-Pak when I have an upper respiratory tract infection? At Ochsner, I've partnered with a couple of docs who see a lot of my MG patients, and they know not to give them a Z-Pak, sorry. And then if you're interested in participating in clinical trials, ask your doc, are you guys doing any clinical trials? Or do you know of any that are open in the area? That's all part of the visit. So the last thing, and somebody alluded to this earlier, make sure you understand what it looks like when it's starting to get worse. For the guys who've been with the disease for a while, you kind of know that, but make sure your doctor knows it. I mentioned that earlier, but make sure your doctor understands what it looks like when it's becoming worse, and develop a plan together for what you're going to do. We'll talk a little bit later about how to do this, but I give my patients my cell phone number and say, look, if you get into a bind at night or on the weekends, or if you can't, for some reason you can't get through to my office during the day, you can call me and tell me what's going on, and I'll help you. And if you are with an ER doc who doesn't want to call me, you hand him my cell phone and say, he's happy to talk to you. You got to make it easy for the people you're asking them. If you're asking somebody to do something, you got to make it easy for them to do it. If they have my cell phone and give it to the doc, that's sort of proof that I want to be called when they go somewhere. But that's part of the emergency plan. It may not be me whose number you have. Maybe you have the nurse's number. Maybe there's a little hotline for the clinic. Whatever it is, carry that with you and be prepared to use it. And then finally, summarize what you heard before you leave the room. Make sure that what you heard was what was said, and both of you are on the same page about what's going to happen next. If they have an electronic medical record, see if you can get a little after-visit summary. Say, can you just type out those instructions for me real quick and print it out? Epic and most EMRs have this little, we call it the AVS, baked into it, so they print out after every visit anyway, and then it takes me 30 seconds to type in my instructions on top of that, and then you have that when you go home. Ask them for educational resources. You guys are all pros here. You know that the MGFA website's really good. There's a ton of stuff on there for y'all. But I tell my patients about it every time they come. If they're not familiar with it, I give them handouts, I give them pamphlets, I give them a bunch of homework when they leave, sort of everything bundled in their hands to go read when they get home. And then ask about caregiver support resources. Are there websites? Are there support groups in the area? Tommy's right here. Tommy runs our support group in New Orleans, and I tell every patient about Tommy. I give him his email address and everything. And they love it. Yeah, Tommy's a rock. So that's the visit day. And then, look, all of this happens pretty fast, as you know, 20 minutes, 30 minutes, 15 minutes in some cases. Don't leave the most important questions on the table. And be honest. If you're not comfortable with what they want to do, if you feel a little shaky about it, say so. Let's talk about where we both are and how we're both going to solve this puzzle of this disease. And then figure out your expectations together. What should I expect over the next interval? You're going to see me again in 3 months. What do I do for the next 3 months? What should I expect? When should I call you? When should I leave you alone? And collaborate to build this relationship. Most of us really aren't that good at communicating. We think we are. All of us think we are. But a lot of us just aren't that good. And for any given day, any given moment, we may not communicate well, right? My patient with the relationship, that was a not good communication. And so sometimes we have to teach each other how to talk in the way that we respond to. So the way I talk to patient A is not the same way I talk to patient B. They have different needs, they have different wants. And we have to teach each other how to do that, right? So that the way your internist talks to you and the way your neurologist talks to you may be different. And you have to teach each one of them kind of how it works for you. So this is a little thing to remind me that we exist as patients and consumers. They're not mutually exclusive. They have different rights and responsibilities associated with each. And at any given point in time during your appointment with your physician, you are more one than the other. Okay? You're always a patient, but there are times when you're a consumer. Look, the person that made my appointment was really rude, and I don't appreciate it. She was yelling at me on the phone, telling me blah, 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 blah. That's more of a consumer issue. My doctor doesn't really understand myasthenia. That's a patient issue. My doctor is taking me off these medications that I think I need. That's a different thing. But just remember that this exists, and you toggle between these things all the time, and understand where you're coming from when you're talking. When you have an issue, is this a patient issue? Is this a consumer issue? And that helps you understand where to go with that. But our goal, in order to sort of get your disease under control, get your life back, get you as tip-top as we can, is we want a partnership with everybody that you're going to touch. And we want it to be reasonable and responsible and collaborative, confident, and truthful, right? That's a great set of things to have in a relationship. It takes time, effort, and the will to do this, but it can be done. And it can be done using all these things that you guys kind of already know about. So between visits, again, we're trying to create a partnership with everybody around us. It takes a village to get through this, and that's what you're creating. This is the roadmap. You know, in between visits, you got to understand, well, okay, I was here on the prednisone scale, now I'm coming down here a little bit. I'm on my mestinon is stable. I'm on my immune therapy. All these things are under control. I'm just kind of coasting down to a landing here. Another thing to do, become an MG Pro. All of you are here today because you want to become MG Pros. Some of you already are. Monitor your symptoms. Anybody use the MyMG app? Yeah, a couple? Okay. If you don't know about it, ask around. It's a free app on the App Store, and you can score yourself once a week or so and just kind of see how you're doing. You can bring those numbers into your doc and say, hey, look, man, my MG score is doing really well, or I'm kind of noticing a trend in the wrong direction here. What do we want to do about it? And if you're not the high-tech type, if you don't like doing everything on your phone, then just keep a little notebook. Jot down some things that you notice every week and kind of be prepared to talk to your doc about it. Look for trends and triggers. Does physical activity wipe me out? Boy, that last medication change really killed me. I can't do less than 5 milligrams of prednisone a day. We need to go back up. And I notice when I'm really stressed out and I don't sleep, my MG gets worse, or I need to take naps during the day, or whatever it is. These are things that are important. If you sense a trend in the wrong direction, let your physician know sooner rather than later. I think everybody's kind of mentioned that today. Be gentle and persistent, but be an advocate for yourself or your partner. And if you aren't getting what you need, consider escalation. I call this escalation dominance. Anybody heard of that before? If you need to go above somebody you're talking to, go above somebody you're talking to, but be aware that may be a patient issue, maybe a consumer issue, maybe both. Okay, so most of my patients, even though they have my cell phone, they start with my nurse or my medical assistant, and if they don't get what they need, they'll call me. Hey, look, man, I've been calling your nurse for 3 days and she hasn't responded. I'm not doing well. I need you to help me out. Perfectly appropriate. So don't worry about escalation dominance. Just use it sparingly and use it when you need it. This can happen over days, it can happen over months, or it can happen in the course of an hour in an ER if you're not getting what you need. Okay? Escalation dominance. Follow your breathing and swallowing trends. The nurse who gave the talk before the lunch break had some great pearls in there, especially to start locally. If you're in trouble respiratorily or swallowing-wise, it's best to start local and then transfer. I tell my patients, if you're having an airway issue and you need to either call 911 or go to your local hospital, do it. Call me when you're en route, call me when you get there, or hand your phone over to the ER doc and let them talk to me. I'm happy to do it. But get stable first and then let the dust clear, and we'll get you here if we need to. That's not a problem. We can get you from anywhere in the country, and just about anybody that you're going to see can do that. A couple things. Tommy and I were just kicking some stuff around yesterday, and Tommy, you didn't know I was recording this, but consider starting an article resource site or some other sort of digital resource for your group. If you find really cool articles and you want to save them and let other people read them, maybe there's like a Dropbox site that you can create, and then the other people in your support group, the other people in town can kind of jump in there and read stuff that you find interesting. And then the EMR patient portal, I already told you about that. Emailing your doc ahead of time with like 3 things you really want to talk about is fantastic to me. I think that's great. Okay, I love Axioms. And I said, like I told you, the ER doc had so many great axioms, but here's some that I found to be important in MG. If you want somebody to do something, make it easy for them to do it. So if I want the ER doc to call my doctor, here's a cell phone number. Easy as pie. Lower the barrier of activation. If I want a patient to go on a medication, I have to explain the medication to them, what the side effects are, what to look for, and I'm going to send an electronic script to their pharmacy so they'll have it when they get home. I got to make it easy. And this is a good one. We are water in a world of rocks. This actually has 2 meanings to me. One is to change, any kind of change occurs over time. So if you need something and you're not getting it from the system or from research or whatever it is that you're doing, it takes persistence and it takes effort. So this is what the advocacy efforts are. Tommy and the other guys at the MGFA are trying to lobby and get people to understand this disease. That's water on a rock, water on a rock. Over time, more and more people become aware of MG, and then our lives will get easier. The other thing it means, though, water flows around things that get in the way, right? It needs to get where it's going. So eventually it's just going to say, okay, I don't want to wait for the rock to change. I'm just going to go around it. I'm going to flow around it. So if you're in a spot where you need to stop banging your head against there, or you need to go around it. If your doc that you're working with doesn't get it, doesn't want to get it, isn't interested in getting it, then you need a new doc. Just go get another doc. So be like water. Just flow around it. Okay, bring me a rock, not that rock. Communication. It's important. We all could get better at it. So if I tell you to bring me a rock and you bring me the wrong rock, I wasn't specific enough. You didn't understand what I wanted you to do. So if I tell you we're going to change this medicine today, and I say it really fast just like I did, you leave there saying, what am I doing? I don't know what I'm supposed to do. So I'm not helping you. So I need to specify what rock, where it is, and how I want you to bring it to me, right? So bring me a rock, not that rock. Strong relationships are built on trust, mutual understanding, and reciprocity. So trust, do you trust your physician? And do I trust you to go out and do what it is that I think you need to do? You need to go down on your prednisone a little bit so your bones stay healthy. Do we trust each other to do the things that we need to do together? Do we have a mutual understanding about what we're trying to do? Do you understand what I'm trying to do with your disease? And do I understand the impact that this disease is having on you and the treatment I'm giving you is having on you? And reciprocity. I'm going to do what you tell me to do, and you're going to listen to me when I come to the clinic. We're going to do this together. It's a partnership. And bring donuts. Always a good idea, wherever you go.